super honored. You guys all hear me okay? Speak loud. All right. I'm really, really honored to be here. It's really special. PMP Pals is an incredibly special organization. I remember, I think the first time that I was involved or asked to speak was in Monterey. I think it was in 2014.
Yeah, something like that.
Yeah. So, and then, yeah, I mean, I've known Adele since I was a Swedish Oncology Fellow, and
yes.
He visits me every day during my fellowship at UPMC at the time.
Yeah. So it's a really special organization, and I love being able to tell patients about PMP Pals. It's just it's a phenomenal resource, and it's been really great. And I'm really honored to speak to this group. It's a special treat. It's very different than any other talks that I get to give, and it's just I really enjoy speaking to this group. So yeah, I definitely do not need until 3 o'clock. So you guys do not need to hear me talk for 45 minutes. But I'm happy. I'll leave plenty of time for questions. We do questions after each talk or at the very end.
We are flexible.
Okay.
So if you have a question and you
yeah,
want to field it, or we can
yeah.
field it after, and then we'll have time at the end for questions from all of the speakers.
Perfect. Well, and if anyone has questions during as well, that's totally fine. Shout out with me. So let me try the clicker, see if it works. It's not good. Okay, well then I'll just put it in. All right, so I was asked to talk about recovery after HITECH, which many in this room have personally experienced or have a loved one who's personally experienced. Some of you personally experienced this more than once. So you should be giving this talk more than me as just an advisor of seeing patients go through this. But yeah, I'll talk about recovery after HITECH. I have no relevant disclosures for this talk. Really, the talk is just kind of divided up into 2 main topics. I'm going to talk about enhanced recovery after surgery, which is traditionally been outside of the cytoreduction HITECH procedures, but now there's a lot of efforts to enroll those pathways and post-operative pathways into cytoreduction HITECH. And then I'm also going to talk a little bit at the end about a clinical trial that we did with one very, very small component of recovery after surgery. And then, like I said, questions. So, all right, so this is a not really a screenshot, but it's a graph that we like to show and brag about at our own institution, and it's on our ECST's HITECH page. We proudly show this, and we are very proud of this. I mean, this is our complication rate. We actually update this about every 6 months with kind of our newest patients, and it's good. I mean, obviously, if you're any of the patients that happen to have any of these complications, it's not good for you, of course, but the rates are overall pretty low. Complications after HITECH have gone down over the years, and that's just due to better techniques, better patient selection, better post-operative care, and so that's great. The problem is we don't always show these things, right? The time to bowel return, right? The time to leave the hospital, the time for full recovery, which can be sometimes several months or longer. And so I think those are the areas that we have a lot of work to do, and we know it's a big operation, and it's a multi-part operation, and there's certainly a lot of recovery that just is going to be inevitable. But there's a lot of things that we do after the surgery or during the surgery that that I think we might be able to do a better job of. Whether it be a Foley catheter, how long do we leave that in? Whether it be a nasogastric tube. I mean, you guys have had nasogastric tubes probably the majority of the room at one point. Pretty miserable. Drains, are certainly something that we talk about, and maybe you can speed up recovery, maybe slow down recovery. And then, how long we keep patients from eating. There's many, many other factors that I think, are opportunities to enhance recovery. And so there's been a lot of efforts. Over the years. Any problems? Oh, there we go. It says I'm using. It's just restarting. That's okay. We'll give it a few minutes. Yeah. I can riff. I can tell a joke. All right. So where were we? So yeah. So the question is, are there ways that we can enhance recovery after surgery? And so there's there's an entire effort. There's a whole sort of experts on this, and the ERAS is the acronym that is used. So ERAS stands for Enhanced Recovery After Surgery. It's really just standardized perioperative care with, that's supposed to kind of attenuate the stress response to any surgery. And the goals of any ERAS sort of protocol are to reduce complications, length of stay, and reduce possibly even costs of surgery. You know, sometimes people call this fast-track surgery or early recovery after surgery, but it's not just about speed necessarily, it's about sort of enhanced recovery as well. So that's what ERAS is. And I think it's important to point out, I know those of you in the back of the room probably don't read all these things, but the ERAS measures exist not just in a post-operative setting, but even way earlier. And so I think you'll see a lot of the sort of the protocols that I'm going to discuss happen in the pre-admission phase, even the first consultation sometimes. The preoperative phase, like immediately before surgery, the intraoperative phase, certainly where we're doing our work, and then the postoperative phase, you know, how patients are managed after surgery. And so some of the common ERAS measures you're going to see throughout this talk is, you know, pre-admission counseling, bowel preparation, we'll talk about that, you know, fasting before surgery, and then carbohydrate loading, which is kind of a newer thing that didn't even exist when I was in my training. You know, pre-anesthesia medications, blood clot prevention, you know, infection prevention, and then all the things that happen during surgery. Anesthesia protocols, prevention of nausea and vomiting, you know, minimally invasive surgery. You know, there's some role in side reduction hypec for that. We can talk about that maybe at the end. You know, avoiding low temperature, nasogastric tube drainage, fluid management, and then all the postoperative care that we do. So these are kind of just general types of things that are included in enhanced recovery pathways. And so there's been a lot of guidelines developed over the years in various kinds of surgery that include enhanced recovery. The earliest sort of efforts were in colon surgery, just in colectomies. The colorectal surgeon and their anesthesia colleagues have kind of developed these pathways going way back to 2005. So they've been around for a while. But you can see that other types of surgeries have also now have guidelines for ERAS. So pancreatic resections, gastric resections. You know, there's just general ERAS protocols for anesthesiologists actually now. Gynecologic surgery, bariatric surgery, liver surgery, you know, head and neck surgery, and even breast reconstruction. So a lot of guidelines exist, and these are always changing, and there's more coming online all the time. This slide's probably now out of date. I should also mention, it's hard to read at the very bottom, but my colleague, Gyula Virpog, I don't think he's here yet, but he's going to show up, I think, later tonight. One of my colleagues at UCSD is really our ERAS champion, so I'm really stealing most of his slides. So I'm actually glad he's not here, so you can't see this, but I told him I'd at least give him credit. So he's actually our ERAS champion. We'll talk a little bit, I'll mention a little bit what we're doing at UCSD, and he's a big part of that effort, but this slide and many others come from him. So just as an example, this is kind of a big study that was done in colorectal surgery, where they combined multiple randomized controlled trials and multiple patients, and you know, many of these trials included various ERAS elements, right? Some of those things I talked about, you know, NG2 management, early Foley removal, etc. And in general, you know, this meta-analysis found that in colon surgery, at least, you know, doing ERAS reduces the length of stay by almost 2 days, actually. Two-day difference stay in the hospital, which is quite a bit, right? And the hospital administrator loves to see that, right? Because that's saving them a lot of cost, but it's also saving you guys from being in the hospital for 2 days. So it's really beneficial. Overall complications were also reduced in this big meta-analysis, you know, almost by half, not quite, 30% reduction in complications. And then there was no change in readmissions or mortality. And I think, you know, anytime, you know, there's lots of efforts we do to get people out of the hospital faster, but we always have to look at readmission rates, right? Because sometimes there's a yin and yang of that, right? The sooner we push people out of the hospital, sometimes that results in a readmission too. So we got to be careful to look at readmissions. And most of the well-designed ERAS studies look at readmission rates as well, because we don't want that either. And so those are things that are looked at. So I'm by no means going to go over this long laundry list of things, but and those of you only in the front row can probably read this. But many guidelines, these guidelines now for colorectal surgery have been established for a really long time, and they are used, you know, quite frequently. And they include, you know, all these things listed here. And once again, you don't need to go through them all, but I just highlight a couple. You know, pre-op optimization and counseling. You know, part of that is just education of patients when they come in to see us. You know, what is the surgery? What's the recovery going to look like? Just from the very outset, just to kind of set the stage, because I think that's, you know, because everyone reads things on the internet and talks to friends, and you know, if they talk to you folks all, they would get good information. But unfortunately, we know that doesn't happen. And so that's a big part of this. Bowel preparation. So the ERAS guidelines for colon surgery, the official party line is actually only to do selective bowel preparation, right? So we can talk about that in the setting of side reduction and HIPEC. Now that's clearly, bowel preparations are still done, right, routinely. But the actual ERAS guidelines, there's lots and lots of studies on this. And the pendulum has kind of swung over the years, you know. Used to be patients would get admitted to the hospital the day before for surgery before their bowel prep, so they could have their bowel prep. And then the pendulum kind of swung away from bowel preparations. It's kind of where we are now. But there's now some more recent studies that have shown maybe if you add antibiotics to it, there's actually some use of adding antibiotics with the bowel prep. So that's a whole other discussion, but the pendulum kind of seems to go back and forth. But, you know, routine bowel preparation is actually not recommended according to these guidelines. This is for colon surgery. We'll talk about side reduction and HIPEC, but that may be a good news to many people, perhaps. So, you know, preoperative fasting, and then in the preoperative period, you know, anesthesia medications, prophylaxis of infection, you know, all the intraoperative pathways, drains, you know, routine drains by the colorectal societies are not recommended. Nasogastric tubes are not recommended, you know, for colon surgery, as routine colon surgery. Now, we can talk about whether that actually happens, but these are the guidelines, right? And so this is what for colorectal surgery. And then, you know, all the postoperative things that we showed here, early removal of Foley catheters, you know, glucose control, etc. So I think that one thing is preoperative. I'll just highlight one other thing on this is preoperative carbohydrate loading. Have you guys, is anyone familiar with that? Have you guys seen that before? That's something that we recently started to do. Yeah. So the idea is, you know, we starve people before surgery, right? Just to be punitive. No, because we don't want people to be vomiting, right? So that's, you don't have a stomach full of fluid when you get intubated, and then you can aspirate. It's a big problem. But the problem is your body goes into kind of a catabolic state when it's starving, right? It's just trying to survive, right? So you start to chew up your own fat and muscle and that kind of stuff. And so the idea of carbohydrate loading is you can kind of mitigate some of those catabolic effects if you give a high glucose, you know, solution. It's a little bit counterintuitive. We think about sugars, and sugars are bad, and you know. But the reality is that the theory is, at least, that it actually mitigates that kind of catabolic response. And so, and you can take them up to, in some places, up to 2 hours prior to surgery. So that's kind of one thing that we started to do, and we'll talk a little bit about that. But I just bring that up because that's something that was new to me, certainly even in the last few years. And so, but that's been in the guidelines for a while now for colorectal surgery. So, but I think it's important to point out, you know, I'm not going to have any boring pictures, by the way, in my talk. This is as boring as it gets, right? So, no, but I think it's important to remember, you know, the guidelines I just showed were all for colon surgery, right? We know a laparoscopic right colectomy is very different than a side reduction in HIPEC, right? A 2-hour laparoscopic surgery that has maybe a 3 or 4 day stay in the hospital is very different than what we do. And I think that's the challenge, right? That's the challenge with enhanced recovery after side reduction in HIPEC. And so, and I think one study that highlights this is, you know, we were part of this, and many other groups across the country were part of this collaborative kind of registry type study. And this study looked at about a little over 2,000 side reduction and HIPEC procedures at 12 different institutions, just to look at how patients were managed after surgery. And no surprise, perhaps, it's very different, right? You get your HIPEC done at one institution, it's going to end, your recovery may look very different. The kinds of things that are done are going to be different at different institutions. And they found a wide range of practices. They also found a pretty wide range of complications and readmission rates. And the point of this was not to kind of, you know, find out what's the best institution. The point was to try to look at this variability. And so, once again, I'll kind of take through these if you can't read them. So these are just a list of the different types of intraoperative and postoperative practices, you know, during and after cytoreductive surgery and HIPEC at various institutions. So, for example, the first line is drains. You know, the median drain across all institutions is 1, but the range is 0 to 3. You know, and you know, for example, you can go down the list. You know, prophylactic preventative chest tube. You know, 18% across the board, but the range is 0% at some institutions to 50% at other institutions, right? So there's a wide variability here. And then post-operative, nasogastric tube, duration 3 days on average, but some institutions the average was actually up to 6 days. Some were 0. They probably didn't even use them. And so, there's a lot of variability. ICU stay, blood transfusions. And then what the authors of this study did, which is really interesting, is they looked at the variability by institution. How much of this variability between the institutions were actually because of just institutional practices, right? This is how we do it at UCSD or wherever. And they found that also varies. Some of these practices, like whether patients got extubated in the OR, was largely driven by their institutional practice, probably by their anesthesia groups that just said, these are long cases, we're going to keep patients intubated overnight. And other institutions don't do that. But some of these practices are only in part based on the institution policy, suggesting that some of the variability is actually just due to different patients and different surgeons, right? So you have practices that vary by institution, but you also have practices that vary by surgeon and by patient. And probably by procedure, really, right? Because as we all know, one-sided reduction is not the same as another one, depending on how much disease there is and how much we have to do. So because of this wide variability, and especially in recovery, there's been multiple groups around the world that do HIPEC that have looked at, trying to establish ERAS protocols at their institutions, and they published this. Now, most of these studies are not true, like randomized controlled trials, right, where you enroll and you get randomized to either the ERAS arm or you get all these different pathways for the non-ERAS arm. Most of these are pre and post kind of studies, right? So our institution did this for so many years. Now we're going to institute an ERAS protocol, and that may include any number of things. And it's not the same in each institution, right? The ERAS protocol is different. But if you look at these studies, and they vary, like I said, from Ohio State to Mayo to Brigham to Turkey, to Louisville, UIC in Chicago, some of these studies are pretty small patient numbers. But if you look at the complication column, some studies showed no difference in complications in the pre-ERAS era and the post-ERAS era. But some of them had a pretty big reduction in complications, like Turkey, for example. This is serious complications that they get. 10% versus 1.6%. And some had other, pretty big reductions in complications. Length of stay, pretty much at all but one institution, they found a reduction in length of stay. Now, some of this could be just contemporary practices, and there's more efforts now to get patients out of the hospital sooner. So some of it may just be driven by that, but, because there's a lot of things happening at once. But the ERAS protocols could be in part responsible for this. And then the other things, the readmission rates when they were looked at in these studies were pretty much equal, right? That's good, like I said before. You don't want to see a worse readmission rate. You don't want that cost to be the benefit of, of an earlier discharge. And so they were fortunately about the same across the groups. And some of these studies showed reduction in, narcotic use and IV fluids. And so seems to be some benefits, at least in these small studies at these institutions, from using these ERAS protocols. And so the ERAS Society, which for cytokine reduction and HIPEC includes about 24 members. Dr. Birpong in our institution is one of those members. And they did this sort of consensus-based guidelines establishment for cytokine reduction and HIPEC. So these are this laundry list of 28 things of what the ERAS Society recommends for enhanced recovery after cytokine reduction and HIPEC. And, like I said, I don't need to go through them all individually, but I think, we talked about the pre-admission, and many of these things are carried over from the colorectal, guidelines. But, cytokine reduction and HIPEC is not the same as colorectal surgery, so there's some different ones here. The one thing that's here is pre-exercise or prehab, right? Prehabilitation, kind of, getting yourself ready as if you're training for a marathon, before, because kind of what a cytokine reduction and HIPEC is. And so, that's something that, a lot of institutions are starting to establish, is kind of have a whole prehab, physical therapist that works with patients before. Now, many times we don't have that luxury of time, and, we have to more urgent, we have to do surgery sooner. But that's part of this. Nutritional care, screening. I think that's the big thing, is screening patients before surgery about their nutritional care. Are they malnourished? And if so, should we boost that? And how should we boost that before surgery? Preoperative anesthetic assessment, valve preparation. So valve preparations, according to the guidelines that exist here, are also not routinely recommended for cytokine reduction. Now, to be fair, we usually still do them. So we break these rules, and many institutions do. But I would say we've probably gotten a little more selective as well. And maybe as there's, like I said before, some ongoing studies about adding antibiotics to bowel prep. Does that make bowel preps worthwhile? Yeah.
If you don't do bowel prep, what type of challenges does
Yeah.
that give you indoor?
Yeah.
And how do you clean the inside of the colon
Yeah.
prior to?
Yeah, I mean, that's always the argument about the bowel prep. It's like we're dealing, if you have to do a colon resection and it's full of stool, that's generally just logic is not a good thing, right? But it turns out, you know, most of the time, and you know, as a surgeon, I like it if someone's bowel prep. It's nice, it's easier to operate on the colon, and I worry a little bit less about putting the colon back together. But honestly, with staplers and things, the colon is never really even opened that much, right? The stapler kind of seals and staples and cuts at the same time. And so it turns out when the data's been looked at, it hasn't really translated much into better outcomes.
Now, say, I recall hearing when HIPEC was done, we would leave the bowel open. But I don't know if that's how it's done now.
Well, like maybe for during the HIPEC part. Yeah, so sometimes we do the bowel resection during the site of reduction and then do the anastomosis. Some people do the anastomosis at the end after the HIPEC. But you're doing it at some point anyway. And yeah, if there's stool in the colon, then the thought was it's just, you know, more likely to leak or get infected. And now, you know, it may be that antibiotics are more important, right? That it's not the actual clean out of the colon, it's just sterilizing it a little bit, you know. So yeah, so that's exactly right. And because of that, it's a hard culture shift though, right? So like I said, even at our institution, you know, we certainly still do bowel preps most of the time. But you know, that's kind of the guidelines. And pre-op fasting and carbohydrate, you know, loading are recommended. So pre-op fasting, it's actually to reduce the amount of fasting you have to do, right? So, you know, people used to have to do 24 hours, I think, you know, way back. Now it's really 6 hours of solid food fasting and up to only 2 hours of liquid fasting before surgery. So that whole like complete NPO after midnight is not recommended actually. You know, pre-anesthetic medications, it's a whole laundry list of things. Antimicrobial prophylaxis, so pre-op antibiotics and skin preparation. We'll talk about kind of how we approach that, UCSD, but very different places. Post-operative nausea, vomiting, you know, getting anesthesia to give post-operative nausea medications preemptively, right? Like before it actually happens in the OR as part of the protocol. Normothermia is kind of an interesting one, right? So that means normal temperature, right? So, well, we're doing HIPEC, right? So that's not normothermia, right? In fact, what's been found historically is people that you know, most people get cold in the OR. Most patients are cold. The OR is a cold place. You guys know, when you get there, you don't want to talk to you about it. It's chilly. And when patients are opened up and surgery's happening, they're not wearing warm clothes, of course. You know, so patients tend to get cooled and their body temperature drops, and that's definitely associated with increased infections. And so most of normothermia historically has been trying to keep patients' temperature at an adequate level. But what happens in our OR still is, you know, our anesthesiologists will like to pre-cool sometimes. Like we know we're going to do HIPEC, we don't want the temperature to go too high, so we'll actually let patients get colder before we do the HIPEC. And then that way when we give HIPEC, their temperature doesn't, you know, the abdominal temperature of course goes hot, but their core temperature doesn't go as high. But that's actually maybe not the best practice, you know, maybe that's not the best way to go about it. So, you know, the guidelines recommend trying to keep it as normothermic as possible. Glucose management, also trying to keep people's glucose in that narrow range that we like to see. Transfusions, really the recommendation here is trying to minimize routine transfusions. We'll only use blood transfusions in those cases where it's actually needed, where there's blood being lost and patients are, you know, have effects from that. Drains, so the recommendation here is actually not to use routine drains, you know, not to put drains in just because. Drains are, if you want to get a surgeon riled up, talk about drains. We love to talk about drains. We do studies on drains, and the jury's still out. It's really largely surgeon preference. You know, when we put a drain, how many drains, what kind of drain, when we pull the drain. I mean, our residents, you know, they get different things from us all the time. They try to drive them crazy. But the recommendation, you know, from the guidelines are actually not to just do routine drains, just because that's what we always do. You know, to have a reason for that. You know, maybe we're worried about this anastomosis that they leak, but don't just do it routinely. Nasogastric drainage is actually not recommended either by the guidelines after site reduction and HIPEC. You know, our practice at our institution is actually to do G-tubes a lot of times, which some ways are better, some ways are worse, right? It's a tube directly in the stomach. We have to pull it out in the clinic, usually after discharge, so that's the hassle. but it's not a tube in the nose. But maybe we don't even need to do G-tubes. And I would say that practice is also changing a little for us, but we're kind of slow to adopt this. But the guidelines are certainly patients that are high risk to aspirate. They have poor ability to protect their airway. It's probably good to have a way to decompress the stomach because it's bad if you aspirate vomit the lungs after surgery. So certainly the guidelines make accommodations for that. They're not saying no one should ever get a nasogastric tube. It's just routine use of nasogastric tube is not recommended. And there's lots of studies looking at not HIPEC surgeries but other surgeries that nasogastric tubes meant slow down just because they just make you miserable. You're not eating, and it requires more pain meds, and there's sinus infections that can happen and things like that. And then in the postoperative period, definitely the recommendation here is for early extubation. Ideally in the OR, cut the breathing tube out at the end of the surgery, not kept on the ventilator overnight. Urinary catheters, the guidelines I think recommend about 48 hours, max of having a whole catheter in place. Obviously there's exceptions to this, but prevention of postoperative ileus, including laxatives, certain valve regimen after surgery, postoperative pain management, there's the guidelines, and each of these points, I would say, if you're curious and you really want to dive deep in this, certainly you can look up these papers, and each of these 28 guidelines have a whole laundry list of sub-bullet points, so I'm just kind of touching on some of the highlights. But postoperative anesthesia, the recommendation here is to use, certainly the pain button, the PCA, but also other adjunctive pain medications, epidurals, lidocaine patches, maybe even ketamine or other non-narcotic medications, IV Tylenol, things to try to minimize the amount of IV medications after surgery. Postoperative nutrition, glucose, blood clot prevention. The kind of unique things here for HIPEC are really here, right? So prevention and early detection and treatment of HIPEC complications. That's kind of a vague thing. The details of this one are really things related specifically to HIPEC. So the guidelines give recommendations on what they think the doses of the HIPEC drugs should be. There's a wide range of doses that we use across the country in drugs. And they try to narrow that a little bit from a safety standpoint, giving, for example, the patients get cisplatin, that can affect your kidney function. So the recommendations here are to give a drug called sodium thiosulfate in the OR, which can help protect the kidneys. That's not done everywhere, and so they're trying to just get some consensus around that. I think the other things it includes here, they recommend not using routine ureteral stents, so putting stents in the ureter to help identify the ureters. I mean, sometimes it's needed, but the guidelines recommend just to not do it routinely. And then there's some other recommendations about when to stop chemotherapy and Avastin before surgery, to make sure there's enough time off of chemo and Avastin before surgery. Those are kind of so those are obviously things that are unique to our population, to this. And then the post-discharge care after cytoreduction and HIPEC, the recommendations here are really for physical therapy and nutrition. And it's not that everyone needs to see a physical therapist or have a nutritionist, but just have those services available for patients that need them. And so, a lot of these things are common sense, right? A lot of these things are things that we probably should be doing all the time. But it's just trying to define, a little bit more of a formalized, standardized way of taking care of patients. And that's kind of what these guidelines do. However, there are still challenges, right? There's still a lot of challenges. I mentioned a lot of things that we don't do that are recommended here at our institution. There's still, very heterogeneous disease. When we go in and start a cytoreduction HIPEC case, we never really know how long it's going to take. It's super frustrating to talk to patients ahead of time for that, but that's really the case. We really don't know what we're getting into until we take a look and see. And I think there's a wide range of extent of disease and how many visceral resections we're going to have to do, reconnections, how long it's going to take. And it's often hard to predict that up front, right? It's hard to predict ahead of time, And so a lot of these ERAS measures are done in the preoperative or pre-admission phase when we don't even know how extensive the surgery is going to be, because some of these things may not be needed, if it's not going to be as extensive a procedure. And then surgeon resistance, right? So we surgeons are creatures of habit. We don't like to change because if things are working, if it's not broke, don't fix it, right? That's very much a surgeon's mantra, right? We don't like to make a lot of drastic changes because we like to do things the way we do them, the way we're taught, the way we're trained, and we have good outcomes. We don't like to change, and that serves us well for the most part. But there's also the modern ways to do things that we can all learn from too. And I think that's a real challenge here. So I'll just show a few slides here about what we've done at our institution. And, this is not unique to UCSD. These things are being done in many cyber reduction high-tech centers across the country. But this is kind of our own approach. And once again, I give full credit to our ERAS team and Dr. Bierbaum for really helping championing this. So I think the key is to have kind of a main champion of this. And it's a nurse at our institution that kind of really is the ERAS champion. She's not just the ERAS champion for cyber reduction high-tech, it's for all of ERAS. So it includes people getting colon surgery, hepatectomies, Whipples, pancreas cancer operations, et cetera. And that includes, all the surgeons. If we have a patient that's going to be a potential ERASable, meaning an open, extensive cancer case, we get an email saying, hey, your patient is, potentially an ERASable patient is how it's proved. And so, would you consider doing these measures? And it's just a reminder to us, just a little nudge, right? Just to say, hey, yeah, maybe we should be doing preoperative carbohydrate loading or some of these other measures. And it really helps because, we tend to forget about these things. And then they also look at compliance too, so that we can measure kind of how often are we actually doing the guidelines that we say we want to do. And it's not 100%, that's for sure. There's a patient aspect of it. You guys can't read this, but there's handouts that we give that kind of explain ERAS to patients so that they know what's happening, they know why they're getting this high sugar drink right before surgery. It seems kind of intuitive. Or why we ask them to chew gum after surgery. I have to talk about that. Just trying to set expectations for patients after surgery, and I think that's super important. And it's most of that education is not done by us as a surgeon. It's done by our nurses in our clinics, and we have ERAS nurses that can help with this too. Malnutrition screen is a big one. Just asking people if they've lost weight, what period of time they've lost the weight, was it intentional or not. Some people lose a lot of weight intentionally. That's good for them, but we need to know that at the time. And if not, if it's a lot of weight loss, we need to get that into our nutritional counselors and dietitians and try to boost that. And sometimes that requires IV nutrition or TPN if it's like a real significant predominant portion of their weight that they lost. Obviously we all use electronic medical records now, so some of these order sets, there's an ERAS order set at our institution that many institutions have, and it makes it a little easier to try to implement some of this because there's flags that can come up, you can track if things are being done, what things are being ordered, the old paper handwritten orders, the days are over for good, which is a good thing. And it's way easier to do this now with electronic medical record. And then pre-op carbohydrate loading, we certainly do. We use these two Ensure pre-surgery drinks, kind of 8 to 12 hours before, and then another one is a few hours before anesthesia. We do make exceptions for patients that have significant diabetes, of course, because we don't want them to be hyperglycemic right before surgery. So type 1 diabetics and then significant type 2 diabetics who have an A1C over 7 is our cutoff. We won't do this for. But even someone has type 2 diabetes that's diet controlled, we would still recommend the sugar drinks before surgery for those reasons I mentioned earlier. And then kind of the day of surgery, we do a lot more, we call it nose to toes, triple antisepsis. So, we used to just be the surgical prep, right? We do the surgical prep in the OR, the yellow, betadine solution, which we still use sometimes, but now we do a nasal swab and we do a swab for MRSA, but we also do a nasal prep to clean out, the MRSA that any of us can have in our nose and not know it and bring it into the hospital with us. We use chlorhexidine oral rinses and toothbrushing, before surgery as well, because a lot of the, which I'm sure doesn't taste very good, I've never done it. No, that's not true. I think I did chlorhexidine once with my dentist, so it's not very good, but it's useful. But just to kind of clean out the oral airway and oral areas where there can also be a lot of resistant bugs sometimes that can be brought to the hospital. Skin wipes are done, and then obviously the surgical prep is done. And then anesthesia, we try to use a lot more regional anesthesia, a lot more epidurals, blocks, mostly for abdominal surgeries and epidurals. Try to maintain normal therapy as much as we can. Try not to pre-cool as much as we can. I think the cutoff is like 35 degrees centigrade. We try to keep patients at least above that, which is still pretty cool. But then hyperoxygen, extra oxygen tends to reduce infections as well. And then certainly I've been using for a long time now, preoperative heparin, the operative for blood clots. And so that's part of the ERAS protocol. And then closing protocols, we've switched, and it's been a big culture shift that there's a whole closing tray now. We're doing the operation, we're in the valves and connecting things and HIPEC and all this stuff, and then at the end of the case, we change our gloves and have a whole closing tray that we use with fresh instruments, clean instruments to close the skin because we don't want to contaminate the skin. It seems silly, and I think a lot of us are like, this is stupid, like, does this really do anything? But, we're still collecting the data, so who knows, the difference, but it seems to be different. And that's, that's kind of one of the things that we've done. Post-op care, certainly gum chewing, we try to give clears a little earlier post-op day 0, just to kind of stimulate the GI tract. That's kind of the same idea behind gum. You can't read this, but there's a little, patients get a little pack of gum. I don't know what kind of gum it is, actually. Probably knows. But we get a little pack of gum, and it explains why we're giving them gum after surgery. And then there's also this little enhanced recovery, little bullet checklist that the patients get so that they can just kind of see what they're doing. And then post-operative, blood clot, prophylaxis. Usually we use Lovenox and cytospirometry, and we try to remove Foley's at 48 hours. And also use multimodal analgesia. So we have a pain service. If someone has an epidural, usually the pain service is kind of what manages their pain. And once again, these are not things unique to us at all. And a lot of institutions do this. Many institutions probably do this better than we do. But this is kind of what we've done. Now, there's certainly a lot of next steps. We have plans to do videos. Everyone wants a handout, right? We all want videos now. We live in a world of TikTok, right? We want videos to look at, and so they take a little bit more time to develop. So our ERAS team is trying to put together those. We want to try to onboard our subspecialty services. So not just this kind of started in our colorectal surgeons and with some of us in our surgeon. But now we want to include our spine surgery team and some of our other big cases that are done in our hospital. And then, integrative health rehab, that's like a big part of it, as I mentioned, kind of getting people ready for surgery before surgery, preparing them for the big operation. So the summary of ERAS and HIPEC is, certainly evidence-based ERAS guidelines exist after cytoreduction in HIPEC. ERAS protocols can certainly reduce length of stay and possibly complications after cytoreduction in HIPEC without increasing readmission rates. But there's a lot of implementation challenges, there's a lot of different disease burden, types of procedures, complexity, and just resistance to change, not just by surgeons, but just by institutions. It's hard to get us to do things a lot differently. And then implementation strategies are certainly, a big part of this. It's good to have an ERAS team with a champion and some surgeons and other nurses who are kind of part of that team to kind of help get the hospital culture to change a little bit and to use some of these protocols. It's not been perfect, we've had success getting our hospital management involved so they can kind of speak from their soapbox and loudspeakers to try to get all the culture to change a little bit at our institution. And then kind of a staged implementation process, trying to not bite off everything at once, right? The first ERAS protocols we had did not include 28 items, right? People's eyes are going to glaze over, right? If you have an order set that has 28 things on it, there's no way it's ever going to happen. So Dee Glazer, who is our ERAS champion, was very smart and helped start out just very small, little steps, and kind of you build on that. And then over time, you have a pretty nice order set that people are comfortable with. And then audit, look and make sure that we're actually doing what we're supposed to be doing. And that's sometimes a sobering reality is that we're not really doing this. So I think, maybe what I'll do is I'll stop here. I have some more slides talking a little bit about one particular aspect of post-operative recovery that we did a trial on, the CSD. But it's getting close. Maybe I'll take some questions if there's any questions, and if there's time, I can go to other stuff, and if there's not, it's no big deal. So, yeah.
You had mentioned earlier about the uteral stents.
Yeah.
What would be the purpose? I
Yeah.
had 3 surgeries, and it's been used once for the
Yeah.
but the other 2 were actually.
Yeah, that's a great question. So, the ureters are, the tubes that go from the kidney to the bladder, for those of you who don't know. They kind of run, along the side of the abdomen and then through the pelvis into the bladder. And they're a big problem if they're injured. If the ureters are injured and it's not recognized, then you have a leak, basically. You have a leak from urine into the abdomen. And it's a big problem after surgery, and especially in reoperative surgery. The ureters are little tiny tubes that are sometimes hard to identify. And so if you put stents in them, then as you're operating, you can feel these stents and help to identify the ureters a little bit easier than just normal visual cues that we have. And so that's the argument to use stents. And so the recommendation from the ERAS standpoint is just to not use them routinely. It's a procedure. It's an extra step, right? You're inserting a plastic tube up a ureter, which has some complication, has some risks. I mean, fortunately, the ureters are pretty tough, and it's pretty rare to injure them just with the stent, but it can cause infections and bleeding and pain. And so, if you're using them and you don't need to use them, then perhaps it's better. So, I would say our practice is we don't generally use them routinely, but if someone has had a lot of pelvic surgery before and they have a lot of their tumor burden is now in the pelvis, that might be a case where we want to do the stents, because the ureters may not be in the normal location, they may be scarred and hard to find, and we don't want to injure them, but not to use them routinely. Anyone else? Yes?
I just want to say thank you. He's from 2003.
Yeah.
And the outcomes.
It's changed a lot.
The time out of the hospital, all of these things
Yeah.
are so much better than they were then. And it's just so hopeful to hear things not only be as good as they are now, but all of the dedicated effort system-wide to make it even better. So thank you.
Yeah, I mean, I'm a surgeon, we surgeons take credit for everything. This is a huge team effort. And most of this care is not done by us, right? It's done by our nurses, and it's done by our anesthesia colleagues and great patients, frankly. I mean, if a patient's not going to get out of bed and walk on day 1 or day 2, there's that, we're already behind a little bit, and so there's only so much we can do. So yeah, I mean, it's certainly not just the surgeon effort here.
One more thought comes to mind.
Yeah.
From patient education
Yeah.
standpoint, and I'm sure it's done.
Yeah.
Every institution's different, but educating patients on the drains.
Yeah,
Because a lot of times, we wake up,
yeah.
and then
What is this? Yeah.
we've got all this stuff, and we don't know when it's coming out.
Right.
Right, if we're taking the Foley out in 2 days, then
Yeah.
we've got to navigate to the bathroom with all this
With all
stuff.
this-
Just the information, right, it's going to be out in 5 days, 7 days.
Yeah.
That's very helpful.
It is, and I think that's where that pre-op, training goes into it. If you have a drain, here's the general practice. Now, it's going to be different in some cases, but you're absolutely right. Or going home with the drain is another one. A lot of times sending home patients with drains, and then we don't teach them how to take care of it. Well, then, no surprise, they come back to the clinic and we don't know how much it's put out. We never told you, so yeah.
I want to recommend training the caregivers as well.
Yes.
Because when you
Yes.
train the patients are terrified.
Exactly.
Whatever you say to a patient before surgery,
Right. Exactly.
and the caregivers are terrified too.
Right.
But at least,
It's another set of
there's another voice, another person who can say, oh, this is what I heard.
Yeah, exactly.
Yeah, because it makes a big difference when you think they're just having the abdominal surgery, but when they have the J, all the lines, everything. I remember telling my daughter, because he was in ICU, I had to explain to her what she was going to see, intubated, the NG tube, A-line, all of that. And a lot of people don't get that, and they are scared beyond.
Oh, yeah, it's
Their
terrible.
surgery went well, I'm a caregiver. Surgery went well, but you're seeing all these,
8 bottles.
critical care related things going on, and it's very frightening. And I think it needs to be, upfront with
Yeah. This is what things are going to look like, right? And it's always hard, when we're having that pre-op visit, because we don't know for sure what, are you going to be in the ICU? Maybe. We don't know, Probably not, but, it depends what happens a little bit. And that's always a challenge a little bit, too. So,
I think there's been great strides with communicating better with the patients. Like the videos are going to be extremely helpful because a lot of times you can't even make what gets put down.
yeah.
So the education is definitely improved.
Yeah. We need to get some young people who are good at making videos and make videos for us. People out there that make pretty easy videos. Yeah.
Probably a department about San Diego.
There is actually, yeah. And if you've seen our, we have we've done some videos, and you guys have probably seen some of them, and other institutions have too. And they're really top-notch ones, but yeah, it takes time. Yeah, you have a question?
When Christopher had his last surgery, his arm and leg flat for 13, 15 hours and has muscle damage now. Do you ever do surgeries for that long a time, and what do you do to, or would you do something to prevent that?
Yeah, that's a good question. Yeah, we do. I mean, that's on the long end for sure, but it happens. Yeah, and there's definitely cases that still happen that go that long, and it's, you know, it's you have to be extremely careful with positioning in the OR, and you know, I mean, you know, because it's such a long procedure. You know, we don't think about it. You know, the patient looks like they're laying there comfortable, but they're also paralyzed and you know can't move. So you know, and asleep. And so you know, you're absolutely right. So that's a big part of it too. I do think we have better pads, I think, than we used to have. Like there's a lot more companies out there now that have better mats, and we use special like an extra pad, a mat under patients now for side reduction and hypex, and other long cases like spine cases at our institution, just because of that issue. Because you know, the OR bed is not that comfortable, and there's a little bit better padding, but yeah, I mean that's certainly a consideration. Yeah. Oh, sorry.
Go ahead. I was just going to build on that because I have sensory damage to my femoral nerve from a 12-hour surgery. Is that extra padding something that could be advocated for on the front end? Or what's the best way to communicate that?
Yeah, it's always good to ask, like, hey, you know, just, I mean, never hurts to ask, hey, what kind of OR padding do you use? And, you know, whether it would have helped in any one situation, it's hard to know, you know, but it's certainly worth asking about.
When you're trying to measure outcomes after surgery, what's your endpoint for that? How far are you measuring?
Yeah, I mean, most of these things, I mean, the low-hanging fruit are easy to study. Things like length of stay, complications, you know, we already track all that stuff anyway. So that's easy to measure, and that's kind of what most of these studies measure because they're easy to do. But you probably asking because there's other outcomes that matter too, like quality of life, right? Like, you know, full recovery at home. You know, it's one thing to leave the hospital in 6 days, it's another thing to like fully recover from the surgery. How long does that take? And those are harder to measure, right? There's lots of surveys about quality of life, and you know, Ed Levine at Wake Forest has done a lot of research in quality of life studies, and other groups have, and so there's efforts, but yeah, but you know, true recovery where there's like, you know, full recovery is harder to measure, and I think that's why you don't see that a lot, and that's important. More important probably when you leave the hospital, right? We as, you know, hospital administrators want to know, like, in the hospital, but you know, we all want to know when you're going to get better, you know, when you're going to be back to normal. Harder to measure. Yeah.
One of the most annoying things about surgery was looking at a board right in front of me. It had goals for the day. I'm assuming everybody had that. And I have an imagination. I can be imaginative, and I think, how simple would it be if I had a surgery again to just create a little poster? You have it so prescribed. It's so sequential. It's a task analysis in my field. It's 15 stage steps. If I saw that, then walking on day 3 would have been more motivated for me. Yeah. And I really would have understood where I was. Yeah. It's a challenge to PNP to perhaps create that, at least an online version, a downloadable version. It gives the caregiver something to talk about at least, rather than, did you walk today, or that kind of thing. That's just where you are. And that could be a really nice outcome and very motivating for the surgical team. If, in fact, you're indicating the clients, patients, caregivers, and we're actually asking some of those questions. I think it could actually move the bar quicker.
Yeah, well, that's a great point. Yeah, I mean, I think we see those and we're using those more. And the other thing I think is, you know, the little challenges, right? Like, you know, well, bed, you know, 32B has gotten 6 laps today. Now we have like a single chart in our thing, like who's got the most laps on the day, right? That's not fair, right? Because you're getting a side reduction height vector who has an appendectomy. Right? It's not fair. It's not an easy thing, but it should be adjusted for what your surgery was. There's little motivators like that too.
There's a lot of question when they have the surgery and you know you do your 6 to 8 week post-op visit and then it goes back to an oncologist with PCP. And there are those that there might be some conflict between the oncologist and maybe your recommendation. What do you suggest with your common question within this group. You know, who should they follow up, who should they not, you know? I want your perspective on that.
Yeah, it depends. Part of it is there's logistics behind a lot of that too, right? So that's part of it is, you know, like many of you have traveled very far having your surgery wherever you had it done. And, you know, most of our patients aren't in San Diego. Many aren't even in Southern California, you know? And so that has real implications about who they're going to see. I mean, I think, you know, the silver lining of COVID is we're pretty comfortable with video visits now, right? So that makes it a lot easier to follow up with people who live far away because we feel more comfortable. They've always existed, we just never used them before. But now we're pretty comfortable. So that helps. But yeah, you know, it's always good to ask too, you know, why have you seen you? How often will I be seeing you? If patients are willing to come, you know, we certainly all of us at CSD, we love to see them, you know, whenever they're due for their scans. That's a great time to come see us. If it's 3 months or 6 months or whatever, that's a pretty good schedule. Obviously, it's more frequent than that, right, after surgery, but you're talking sort of as you transition, you know, and yeah, and that's always a challenge. And it also a little bit, you know, personally, I always ask patients how often they want to see me. You know, some people, and I don't take offense if they don't want to see me, right? It's okay. Like, you got ties if you need to, like maybe that my role's done. But some patients really want to see us back, you know, for every scan, you know, and that's fine too, you know. So
Yeah, there's been a few through the years that there was no post-op visit, and I was like,
Yeah.
okay.
Yeah, it's tough. It's tough. You kind of feel like you're on an island, you know.
Yeah. Thank you.
Yeah.
Quality, so you say a lot of times when you go do the operation, not until you have the patient opened up, you really kind of have an idea what you need to do. I'm just curious how the surgeon thinks in terms of a quality of life decision when you have the person open.
Yeah.
You know exactly what you need to do.
It's a great question, and yeah, we don't like to be in a position to have to make that decision for people, you know. But sometimes we have to. I mean, hopefully we've, you know, talked a little bit about different scenarios. You know, colostomy is a great example, right? Like, would you want to? If I felt like the only way I could remove all of your disease would be to do a colostomy, which could be permanent, you know, would you still want to do that? Yes or no? You know, those are the kind of things we try to have those conversations ahead of time. But sometimes you just can't anticipate every possible scenario, right? But yeah, we try to do that as much as we can. We have the person there talking to us. If there's some, you know, certainly you could talk to family. You know, we've done that in a few rare situations where there's a big decision about what to do. And, you know, we can talk to the family in the waiting room, but we try not to do that too often. We try to have most of those kind of what-if scenarios discussed beforehand. But yeah, I mean, sometimes there's that balance between quality of life and, you know, attempt for cure, right? And there's a tension there. And then to be fair, we don't even always know. I mean, a lot of times quality of life is based on what you do in surgery, but then sometimes, you know, everything can go well, and then there's a complication, and then the quality of life suffers because of that complication, which is even harder to anticipate. So there's a lot of variables as well. But yeah, I think the key is trying to have those discussions as much as possible beforehand, you know. And so, and be frank with your surgeon too, and say, hey, look, you know, you know, if you want to do everything possible to, you know, to go for that cure, whatever it takes, ostomy, whatever, that's important for the surgeon to know.
Dr. Baumgartner, we didn't have enough content. But we have more time for questions after we're done with the speakers, and so please, you know, so I'm sure more questions will come up, but before we get Dr. Fasab up here,